Good morning, distinguished guests, ladies and gentlemen, and have a very warm welcome to our honorable guests from Hong Kong Asia Medical Group. Welcome to the international webinar on cardiovascular and structural intervention, a special webinar collaboration from the National Cardiovascular Center Harapan Kita and Hong Kong Asia Medical Group from August 28 to 29, 2023. My name is Mariana and I'm the host for today. I also would like to greet the Honorable Chief Strategy Officer of Hong Kong Asia Medical Group, Mr. Kevin, the President Director of National Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, and all of our directors, our distinguished speakers and moderator and panelists, and everyone here, and also all the participants who are in Zoom. Ladies and gentlemen, this international webinar lecture is divided into two sessions, and each sessions there are two speakers who will present. For the next hour, we will discuss minimal invasive cardiac surgery in Indonesia and the experience of robotic PCI in Japan. And allow me to read to you the agenda for today. First, there will be a welcome remarks by the keynote speaker, Dr. Iwan Dakota, and then introduction and remarks by Mr. Kevin. And next lecture by Mr. Dr. Amin Chubandi, and then followed by a special lecture by Sutomu Fuji MD. And then discussion, and after that, a closing for day one. Okay, without further ado, I would like to invite on the Honorable President Director of National Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, to give a welcome speech and introduction. Please welcome Dr. Iwan Dakota.
Well, thank you very much for the giving opportunity, dear colleagues. Very good morning. I think that we have distinguished guest, Mr. Kevin, on behalf of the Board of Directors of Hong Kong Asia Medical Groups. Very good morning, Mr. Kevin. And then we have also a distinguished speaker coming from China, as well as from Japan. I think that we have Dr. Fujita from Sapporo Heart Center, as well as Professor Sushi from Wuhan Heart Centers. Ladies and gentlemen, actually this morning we will have opening ceremony of the webinar series. This is actually the international webinar series, and within 2 days, we will have a collaboration with the Hong Kong Asia Group hospitals. And then I think that this is a great opportunity to us to join together with the prominent cardiac center from the Asian countries. Then we have a close collaboration actually with the Hong Kong Asia Group hospitals, which they have already several hospitals in China, in Hong Kong, as well as in Japan. I think that with this kind of collaboration is very important for us, not only for our link in Asia, but beyond that we can discuss about the further technology. And we're talking about the transfer of knowledge and skills from the benchmarking cardiac centers. That is very, very interesting. See, as we are talking about the latest cutting-edge technology, and then the issue is regarding to the both cardiovascular intervention as well as for other things, including the structural heart disease interventions. I think both sides have their own experts from Hong Kong, Wuhan hospitals, Wuhan cardiac centers, and Sapporo cardiac centers as well. And then we have our expert, Dr. Amin Chubandi, as well as our prominent doctors, Dr. Radityo. We're talking about the structural heart disease. I hope that all of the participants enjoy this kind of webinar series. So actually it is connecting with the anniversary of our cardiac centers in the mid of November. We will have a lot of webinar series. This is actually part of this kind of international webinar series. I hope that you can enjoy this kind of important topics this morning, and then hopefully that it should be beneficial for your daily practice. Thank you very much. And then I think that on behalf of Board of Directors of National Cardiac Centers, this international webinar series, collaborating with the Asia Hong Kong Medical Group, officially open. Thank you very much.
Thank you, Dr. Iwan Dakota, for the speech. And ladies and gentlemen, now introduction and remarks from the Honorable CSO, Hong Kong Asia Medical Group. Please welcome Mr. Kevin.
Hi, good morning, ladies and gentlemen. My name is Kevin Kosaku Simon, Chief Strategy Officer of Hong Kong Asia Medical. On behalf of our group, I'd like to give a few words. Thank you so much, President Dr. Iwan Dakota, and also Director Dr. Isman for organizing this event, and also fellow top specialists from Harapan Kita. Hong Kong Asia Medical, we are one of the largest private cardiovascular specialized medical group. We're headquartered in Hong Kong. We have hospitals in China, Japan, and also Hong Kong. We have a little shy of 3,000 beds in total, and we practice congenital heart disease, from heart transplant, structural heart, robotic Da Vinci surgery, also Corinda's PCI, which Dr. Fujita will present later. And our first visit to Harapan Kita was February 2nd this year with our chairman, and under the strong leadership of Dr. Iwan Dakota and our leadership team from Asia Medical, we are able to send 9 doctors to be trained in our hospitals this year, and more to come in the following years. And this is our very first event, that collaboration event between NCC Harapan Kita and Asia Medical. And I am very happy to witness this event in person, and hope we can learn from each other, and a long-term relationship for decades, and maybe for the next century to come. So we're looking forward for our long-term collaboration. Thank you.
Thank you so much for Mr. Kevin for the remarks. And ladies and gentlemen, now we have come to our main agenda, the special lectures. Our presentation and this will be moderated by our moderator for today, Isman Firdaus, MD, PhD. And allow me to read his bio. Dr. Isman Firdaus is a senior consultant. Now we have come to our main agenda, the special lectures. Our presentation and this will be moderated by our moderator for today, Isman Firdaus, cardiologist in National Cardiovascular Center. To read his bio. Currently, he is the head of medical department at NCC Harapan Kita, the vice president of Asia Pacific Society of Cardiology. Ladies and gentlemen, let us welcome our moderator for today, Dr. Isman Firdaus.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you, Nina, for nice introductions. Ladies and gentlemen, welcome to the joint international webinar from National Cardiovascular Center Harapan Kita and Hong Kong Asia Hospital Group. The theme of our webinar today is cardiovascular approach management from surgery and interventions. My name is Isman Firdaus, and I'm going to be as a moderator today. Within 6 months, there is the collaboration. There is establishment of collaboration between National Cardiovascular Center Harapan Kita and Hong Kong Asia Hospital Group. Strengthen the collaboration for exchange knowledge, exchange trainings, and also exchange visiting in both institutions. So today we built collaboration today with a webinar, this joint international webinar between NCC HK and HK Asia Hong Kong. So Now we have two outstanding speakers today. From National NCC Harapan Kita side and one from HK, Hongkong Asia Group Hospital side. From National Cardiovascular Center Harapan Kita, we invite Dr. Amin Chubandi. He is one of our prominent cardiovascular surgeon in our hospital, doing many cases in open heart surgery. And the second speaker will be Professor Sutomo Fujita. So of course, from Indonesian doctor know much about Professor Fujita. You know, he is director of Sapporo Heart and Vascular Center in Japan, Hokkaido. So now we already attend here in this meeting. There is that for 5 panelists. The first, Dr. Nanda. Dr. Nanda is the interventional cardiologist in Harapan Kita, and Dr. Dafsah Arifajuzar also is interventional cardiologist. Dr. Suko Adiarto as the senior interventional cardiologist. He expert in vascular intervention, including aortic or endovascular treatment. And also from a surgeon side, there is a Dr. Bagus Herlambang. And the last, Dr. Vidya Gilang Rizki as the interventional cardiologist. So we're starting for the first session. Dr. Amin Chubandi will give the lecture about minimal invasive cardiac surgery, Harapan Kita hospital experience. So it will open our eyes how to treat patients to minimize in everything. Dr. Amin Chubandi is our senior consultant in cardiovascular and thoracic surgery in Harapan Kita Hospital, expert in structural and then the coronary and valvular surgery. Okay, times is yours, Dr. Amin.
Yeah, good morning, everyone. Thank you, Dr. Isman, as a moderator for this session today. I'm Dr. Amin Chubandi. I'm an adult cardiac surgeon from Harapan Kita Hospitals. Thank you for this opportunity, to participate in this session of webinar international with the Hongkong Asia Medical Group. For this time, I will present about the minimally invasive cardiac surgery, or MICS in Indonesia, especially in Harapan Kita hospitals. Okay, slide. Yes, slide, please. As an introduction, you know, throughout the modern era of cardiac surgery, most operations have been performed via median sternotomy with cardiopulmonary bypass. Actually, this paradigm is changing now, however, as cardiovascular surgery is increasingly adopting minimally invasive techniques. Advances in patient evaluation, instrumentation, and operative technique have allowed surgeons to perform a wide variety of complex operations through smaller incisions, and in some cases without cardiopulmonary bypass. Slide. What began in 1990s with the first reports of minimally invasive valve surgery has spread to influence nearly every type of cardiovascular operations performed today. And this evolution is being further spurred by recent developments in percutaneous valve technology. So with patients desiring less invasive operation and the literature supporting decreased blood loss, then shorter hospital length of stay, improved post-operative pain, and better cosmesis. So minimally invasive cardiac surgery should be widely practiced. Slide. So for this time, I will present about the Indonesian experience about the MICS. Between July 2019 to July 2023, about four years, including the pandemic years, of course, we have 52 cases MICS. The mean age is about 39 years old. The youngest patient is 22 years old. And the oldest one is 71 years old. About the gender, we have mostly females, about 67% from the patients overall. So 70 males is about 33%. We have in-hospital mortality for the MICS only in one patient. It's 1.9% in postoperative day 3. The patient is a female, 71 years old, with cause of death, heart failure after 8 hours extubation, maybe because of too early extubation for this patient. We have one reoperation, it's about 1.9% because of bleeding, but can be controlled with MICS access. Slide. Conversion to full sternotomy is only one patient, 1.9% because of uncontrolled bleeding at caudal right pulmonary artery. So we converted to full sternotomy. Patient can be discharged and go home. No post-operative stroke for our patient. No post-operative acute renal failure. No wound infection. No redo cases after discharge and follow-up. Slide. So the operation consists mostly as the closure into 22 cases, about 42%, and mitral valve surgery is 20 cases, 17 cases is mitral valve repair, and 3 of the cases is replacement of the mitral valve. And the mean cross-clamp time for the surgery is about 85 minutes, and CBB time is about 146 minutes. Slide. So it is the description about our minimally invasive cardiac surgery, especially for the valve. For the valve, we always make an incision about 5 to 6 centimeters in the right chest of the patient. The other slide, please, is a picture about our procedure in these hospitals, about the minimally invasive procedure. So the next slide is one patient. We perform MICS of mitral valve repair in this patient. It's a male patient. We perform it. Slide. Another slide, please. And this is the post-operative result of the mitral valve repair with MICS at the right chest area of the patient. It's about 5 centimeters. Slide. It's another cases. It's ASD with tricuspid regurgitation, severe tricuspid regurgitation. We performed MICS, ASD closure, and tricuspid valve repair for the patients, young female. Slide. Okay, slide. Next slide, please. This is the post-operative result of patients in the, it's about 5 centimeters in the right chest area of the patients. Okay, slide. Another cases is about minimal invasive aortic valve replacement and VSD closure of our patients. We perform it in minimally invasive surgery. Slide. We perform the mitral aortic valve replacement with biovalve, tissue valve for this patient, and VSD closure. Slide. This is the post-operative result of patients. Another cases is about coronary cases. Slide, please. We perform two MICS of pump and coronary artery bypass grafting for the patient. Slide. This the minimal invasive coronary surgery. So we perform it with the 6 to 8 centimeters incision at the left thoracic side of the patient. This is the instrument and the situation in the operating theater. Okay, slide. This is our strategy to perform the minimally invasive and coronary surgery. Okay, slide. This is the post-operative result post the patient. In the left side is KVH with the aortic loss clamp, and the other side is off-pump minimal invasive coronary artery surgery. It's about 7 to 8 centimeters in the left area of the patient thoracic side. Okay, slide. So as a conclusion, despite cardiac surgery's progress towards less invasive techniques, where the concomitant advances in perfusion methods, more sophisticated transthoracic echocardiography, and innovations in robotic science are driving changes in clinical practice, some doubts remain regarding its efficacy. So, minimally invasive cardiac surgery has gained popularity over the past decade. Its growth propelled by the drive to welcome the benefits offered by minimal access technique, for example, reduced surgical trauma and less pain. To the realm of cardiac surgery, indeed, patients seek surgical methods that allow them for more rapid return to normal activities, back to normal work with an improved quality of life. In Indonesia, the minimally invasive cardiac surgery has been proven with low mortality, less trauma, less bleeding, less wound infection, better cosmetically result with superior patient satisfaction. And in Indonesia, we are fast facing now with limited resources, high cost procedure and low budget national insurance program coverage for this procedure, minimally invasive. This is our obstacles here now. So in the future, the continued evolutions of endoscopic, robotic, and percutaneous technologies will only increase the ability of surgeons to address cardiovascular disease with decreasing operative trauma. Thank you.
Comprehensive lecture about the minimal invasive reflecting Indonesia experience. Professor Fujita, Professor Fujita, Professor Fujita, are you here? Okay. Before we continue to Professor Fujita, maybe we can discuss first about the first lecture by Dr. Amin. We already have 4 panelists today here. The first, Dr. Bagus Herlambang, you're here. Are you with us, Dr. Bagus? Or we go to Dr. Nanda? Is there any something to discuss about we know that ASD and valvular heart disease and coronary heart disease for this kind of patient, Dr. Amin mentioned it can be approach for surgery with the minimal invasive with less for open heart. Dr. Nanda?
Thank you, Dr. Isman, for giving me an opportunity to comment on this issue. Yeah, I saw from Dr. Amin's data that it's a quite wide range of ages that has been underwent the mini invasive surgical procedure. And how about the range of ages, whether this procedure, the minimal invasive surgery, is more suited to the more younger or to the older age of the patients? Because if I see the data, there's a lot of female patients compared to the male patients, which is usually in the older age, the male patients is dominating the number of procedures. Thank you.
Okay, Dr. Amin, which suitable patient for minimal invasive?
Thank you, Dr. Nanda, for this question. So, in my experience, is the mean age of our patient is 39 years old, and I told before the youngest one is 22 years old, and the oldest one is 71. The wide variety of the age of the patient, I think, is all of the patient can do a minimally invasive surgery in this all of my cases, but we know that above the 70 years old, we face with the surgical risk even for minimally invasive. So in one mortality of my patient is about 71 years old. So I think we can do minimally invasive surgery for all of the ages, but in age above 70 years old, we must be careful because of the age, because this one of the high risk factors in our patients in Indonesia, even for conventional heart surgery. So maybe it's the answers. Thank you.
Thank you, Dr. Amin, for the explanation about which patients suit for minimal invasive surgery. So I want to say hi, Professor Sutomo Fujita. You are with us now. Good morning, Professor Fujita.
Oh, yes.
Hi, how are you, Professor?
Nice to meet you. Okay, good to see you.
See you again, Professor Fujita. So the first session, Dr. Amin Chubandi already talked about the minimal invasive surgery for coronary and valvular and also the ASD. So now your turn for giving the lecture about the robotic PCI. Maybe we in Indonesia cardiologists no experience for robotic PCI, so it is very important, and we are very happy if you gave experience and lecture today. So the screens is yours now.
Okay. Oh, can you share?
Okay.
Okay, can you just
before you start, I will introduce you first. Professor Fujita, Sutomusu Fujita is the President Director of Sapporo Heart and Vascular Center in Sapporo, Hokkaido, Japan. One of the prominent cardiologists in Japan, the member of Japan Society of Cardiology, and expert in robotic and rotablation. And we cardiologists in the world, now we call you as maybe laser cardiologists. Okay, laser cardiology. Okay, Professor Fujita, time is here now.
Okay. Can you see the mic, right? Okay.
Yes. Okay.
Just a moment. Okay. Can you see my slide? Okay.
Right.
Okay. Thank you for inviting me. Good to see you, Isma and Dr. Iwan, thank you for inviting me. Nice to meet you, everyone. I am Dr. Fujita, as mentioned, from the Sapporo Health Center in Hokkaido. I am honored to be here and talk in this meeting. Today, I'm going to talk about the robot and its potential in the future on behalf of Asia Medical Group. First, the current system of Corindus robots, now in its second generation. The Corindus is better acquired with a variety application, including the ability to manipulate a guide catheter. Since October 2021, we decided to introduce a system with future potential. So far, about over 200 cases have been treated safely. Today, I will discuss 5 divided topics. First, what is Corindus? Corindus is the name of the company that created the robot, now acquired by Siemens. What's the Corpus GR system? Corpus GR is second generation robotic system. Today, the process of PCI has not been changed over the past 40 decades. At present, PCI still involves the X-ray exposure and orthopedic risk. And the accuracy of PCI is still a problem in complex regions. So the robotic PCI has emerged as a solution to these problems. The current robot system is divided into a bedside unit and an interventional console cockpit, as you can see. So this is the actual method can be operated from inside or outside the catheter room. We prefer to use the outside catheter room. This is a bedside unit consisting of a robotic drive and arm. And this system allows now with a guide to operate a push and pull and rotate in 5 or 7 French, not available 8 French. The guide wire also can be push and pull and rotate at 1.114, not 1.18. The RX device can be push and pull without rotate. The maximum usable device size is 2.3 French. Therefore, normal OCT and non-Vulcan IVUS cannot be used so far. This is the control console. The control console allows the joystick to operate the device from the left and the wire from the middle and the guide catheter from the right. It can be operated by the monitor on the screen, which can be manipulated to the nearest 1 millimeter advancing. So the advantage about the robot is that some issues. The one is the monitor is close enough to see well. And navigation, wire navigation is automatically, as mentioned later. And measurement is possible. The positioning is very precise to the nearest 1 millimeter. And the good choice, the device is fixed. They're easy to fix. So that is a good advantage of the robot. This is evidence. Some evidence is existed. The CORA PCI trial demonstrated a 99% clinical success rate in complex region compared to procedure times as same is with a manual PCI. And the precise trial demonstrated a 95% reduction in radiation exposure to primary operator. And also the JRC published a single center trial showed the reduced patient radiation dose with robotic compared to manual PCI. At a study comparing robotic to manual PCI for measurement accuracy showed the reduced stent uses. There are clinical evidence. And next is next topic is improve the capability and the usability. Today I'm focusing about the utilize the technique and the guide cut manipulation and the expand case application. So first is let's talk about what is application technique. Technique. Technique is a smart procedure automation, is a set of the automated robotic movement designed for the second generation Corpus GR system. Various applications are included. This is now is an operation technique function. Currently equipped application are first is the R1R, wiggle and spin and dotter and the constant speed. So first is I'm gonna talk in detail in later. and how to selection the technique. It is easy can be easy to on the screen selection. I will show you the R1R. R1R is an automatically rotated wire when joystick is retracted to redirect the tip of the guide wire. As you can see, the retracted move the rotate the wire 225 clockwise. Every time joystick is retracted. So I can select it sometimes retraction, advance and retraction. I can get the image and advancing the branch. So this is a very good option. And use of R1R application, the result is a 53% reduction in wiring time. And it might improve the procedure efficacy. Next is this is a wiggle. Wiggle is like an oscillation the guide wire while advancing, as you can see. This is only a guide wire. This is very important wire manipulation. They're easy to advance the wire. Next is a spin. Spin is a full clockwise and counterclockwise rotation of the guide wire while advancing. As you can see, clockwise and counterclockwise. Okay. This is very effective to advance the guide wire. Next is a guide catheter can be pushed. Guide catheter movement. The guide catheter can be pushed and retract and rotate in this manner, as you can see. Okay. Next, I will show you the guide catheter manipulation case. This case is a guide catheter is disengaged during setup. The first preparation by a junior operator, the guide catheter is engaged, but set up the guide wire to the balloon. Next, it is my turn. So I advance the wire, but wire doesn't advance the RCA. I feel that this is a guiding catheter is disengaged during setup. Okay, I check angio. Okay, this is the aorta. Guiding catheter disengaged. So I try to manipulate the guide catheter is reinsert into the coronary artery. First is retract and advance. Next counterclockwise. Next clockwise. So engaged easily. Then advance the guide wire to using maybe this is a wiggle. And retract R1R wiggle. This is severe stenosis. So I advance retrieve. So easy to advance across the region. So as you can see, that it is not so difficult to manipulate the guiding catheter. Next is a topic is a conformability for operator. In catheter room procedure or in catheterization procedure, we are always exposed to radiation and orthopedic risk of wearing a lead apron. Then we are always suffered from the cataract and back pain and lumbar hernia and so on. So robotic PCR can be placed outside the catheter room. This is advantage, no heavy lead apron, no radiation exposure. And this is a good option, the close-up view of the fine screen, well seen, on a comfortable chair, and sometimes sipping coffee. And it is a cockpit. We can see all the information, and we can see well than usual manual PCI. It is one of the merit. This cockpit strategy is the upper side the PACS, and right side is the monitor, vital, and OCT. And as you can see, the bottom side, the center is a monitor, real-time monitor, field monitor. This is a good option. Next is a advanced application case. This is the limitation of the robot. First is that it cannot be suitable for CTO and developing device. Also, OCT and IBUS cannot be used except for the volcano. And microcatheter also cannot be used. And FFR cannot measure because the FFR wire is flipped and in the system. However, other things are possible. Example is a decay crush and the laser and IWL can be used in this with the robot. This is our robotic PCR procedure. First, manual puncture. Next is the vessel diameter is measured by CT. First, and the wire and the balloon are inserted. Then the wire is passed through, and the balloon is dilated. The next is the lesion length is measured by the robotic using markers on the balloon as a guide to determine the next stent size or length. The stent size is adjusted according to the actual region and the balloon measurement by CT. As you can see, so we don't need an IBUS. But the final, this is in Japan, I check IBUS is good or not. A position check. There are our top tips of the robotic PCR. Firstly, according to CT, initial balloon size is decided pre-operatively. This merited either it contributes to saving time of the pre-IBUS. Next is the plan, the balloon as well as the guide wire are loaded together from the beginning. This merit is saving time of the device exchange. The RX balloon sometimes supports the guide wire as a microcatheter. The next guide wire, Minamo, made by Asahi Intec, is the best for the robotic wire. This excellent durability and the torque response match robotic wiring. Sometimes robotic wiring, during robotic wirings, we can see the guide wire is knuckle. So another wire, the expect Minamo, is a knuckle, if the knuckle wire. It's very difficult to control the next step of the guide wiring. But the Minamo is a recover automatically, so easy to cross another region. So I'd like to use Minamo, the first. Here is our experience. In about 1 year and 8 months, we have experienced 201 cases so far. So, this age is like that, as you can see. Most of the cases were type B2 region, not so easy case. The robotic was not used for simple region. And the primary target vessel region RCA is most cases. Region characteristics, as you can see. Not so. Classified region is very rare because it's a robotic is very difficult to use a combined rotablator. And final strategy on most cases DES. And process time is, as you can see, the 15.4. And process time is 14. And class user is very low. And the radius also is very low. And clinical success rate is 100%. But technical success is 90% because the unplanned conversion robotic to manual is about 10%. Many of the unplanned manual conversion are cases in which the guide wire could not be crossed, as you can see. And many cases are early experience so far. Next, I will show you the bifurcation region cases. As you can see, LED bifurcation case. As you can see, by CT shows the bifurcation region with small classification. CAG also shows the LED bifurcation region. Next step, this is our strategy paper. The preoperative CTA reviewed the coronary artery diameter about 3.2 or 3.5. Then the balloon size for PCI was determined to be about 3 mm. The preoperative strategy, 3 mm NC balloon with a wire. But as you can see, this is the first guide wire to DX. The robotic using first wiring to diagonal branch, the protection of the side branch occlusion. This is the wiggle mode and easy to control and retract and R wire tip is a change. This is knuckle wire. This is easy. Next step is change the guide wire and loading a 3.0 balloon. Next is the LED wiring. So it is easy. But this is a septal branch. So retract, they rotate it around the mode, and advancing wheel mode. So easy to get the distal LED. I retracted and advance. Okay, next step is a check angio. And I put the device balloon, which is decided to the CTA 3.0. This is a good position. So as a ballooning 3.0 and 20 atmosphere. But as you can see, the balloon is a little bit more than from the angio image. So I decided the next stent size is 3.5. And this is measured the region length by using a robot. So region length is 20 millimeter. So I decided stent size is 3.5, but 3.5, 20 stent size. This is the wire accidentally removed. That is one of the problem. But during the robotics, the wire is fixed. So I reinserted the LED more distally. Okay. So next step is a stent delivery. Stent delivery is very easy. Yes, this is a stent 3.5, 20. Then I put the stent precisely by 1 millimeter opposite, 1 millimeter advancing. And this 14 atmosphere. Down, deflate. So we check the perforation check. Okay, perforation okay. But unfortunately, diagonal branch is some stenosis. Next, proximal is 16 atmosphere. Then retracted the balloon. Okay. The check follow the diagonal branch re-stenosis. So I decided the kissing balloon technique. So after stenting, we need to do kissing balloon technique and recross the guide wire to LED, from LED to diagonal. Okay. This is use the R1. I manipulated the R1. So advance. First is manually, but it's difficult to operate. But I'm lucky to recross the diagonal branch with the R1. Okay. Next is a previous guide wire of the diagonal wire is retracted by manually. Okay. So this wire next is a diagonal balloon is advancing. 2.25 is advancing by robot. Sometimes it's difficult to cross, but easy. Next step is change the wire. The balloon was advancing diagonal. After that, the diagonal wire and the balloon is changed to the so-called parking route. Next is a LED with a POVA 3.0 advancing robotic. This wire knuckle shape. But in this situation, easy to correct the wire position, wire shape. I advance a balloon like a micro catheter. I advance a balloon. So pull back the guide wire. So pull back the guide wire. Then, okay, yes, correct. So advance bailout, advance LED. But easy to collapse the circumflex. So it's lucky to advance LED. So knuckle. In this situation is lucky. So we advance a guide wire with a knuckle wiring. Next is a balloon advancing. Okay. So now is a assisted LED balloon is a robot, but the diagonal balloon position is a manual. First is the diagonal balloon, 14 atmosphere. Next is the LED balloon. Next is the kissing balloon technique. Okay, it adjusted the kissing balloon. Kissing balloon 8 atmosphere. So almost done. Is maybe the finish. The diagonal branch officer sometimes not so good. I feel so. I report balloon. The kissing balloon over 14 atmosphere is a one slip and pull back the LED balloon 14. Okay, good. Down, deflate. So I check Angel. Great, good. So I pull back the guide wire and the balloon. So I check IBUS. This is IBUS is manually. Okay, good. Okay. Anjo? Where's final Anjo? Is that good? Okay. So next is final topics. The future project. The future project include the remote robotic evolution, robotics, and R1 new system. Currently, a pilot robotic PCR was remotely done in India and the USA. It was remotely operated for about 20 miles away is done. But our Hokkaido is another potential location for telerobotic PCI. So we would like to do so in the future. But currently cannot be done because of the legal issues. This is items that we would like to see developed in the future, include the remote system mentioned before, the ability to use a microcatheter, the ability to use imaging and physiology, and the ability to use a CTO. So this is big news. The Corindus suspended the development of robot. All current Corindus will be retrieved. Unfortunately, we have had to give up robotic therapy. But a saver appears. So it is this is another robotic PCR system. Name is R1, made by Microport in Shanghai. Maybe the PCR shows a R1 system. R1 is a system similar to Corindus. The main difference from the Corindus is that the guiding catheter cannot be controlled so far. Now the device and the wire only can be controlled. They are similar in the appearance. Notably, it is a wire manipulation is so different. The wire is sandwiched between two plates and twists and turns like a finger. This makes the wire much easier to manipulate than the corindus. I think so, yeah. The corindus are similar to those of the the controls are similar to those of the corindus, but simpler, and the devices are more easily interchangeable. It is easy to change catheter corindus. This is R1 trial in China is good, and this is here the comparison with the past trial. Green is a precise trial for corindus. There is no difference in the data. As you can see, the technical success rate and the exposure and operation time is no difference in the previous data. So even if corindus is no longer available, this R1 will allow us to continue with the robot. So conclusion, there is no doubt that our robotic PCI has huge potential for expanding our capability in the CATE lab. We will continue to purposefully practice the workflow of robotic PCI to improve our procedure and unleash the potential of this futuristic technology. So let's get started robotic PCI preparing for the upcoming future. Thank you for your kind attendance. Thank you.
Thank you. You're tremendous. We are lucky to listen your lecture today. So we are now here for panelists. We'll extrapolate and discuss with both from you and from Dr. Amin. First, mungkin Dr. Suko. Dr. Suko first. Dr. Suko is the expert in intervention cardiologist and also as endovascular in Harapan Kita Hospital. Okay, time is yours, Dr. Suko.
Good morning. Thank you very much, Fujita Sensei, for the very nice lecture. Very advanced technology. So I really enjoy your lecture. I might have 2 or 3 questions. My first question would be, in your data, I saw several % of conversion into manual PCI. May we know what was the reasons of conversion into manual PCI? Second question would be, the data is so good that we wonder whether this robotic PCI may encounter some complications during PCI. So my questions would be, how do we anticipate complications during robotic PCI? And the third questions will be the radiations. We understand that the dose of radiations for operators should be very, very low as compared to manual PCI. But you also show that the radiation for the patients is also lower.
Yeah.
Can you tell us how these patients also get a lower radiation? Thank you very much.
Okay, thank you. Thank you. So nice question. So first is the reason of the manual conversion is mostly cases via recrossing. So I mentioned that mostly cases are early experience. So far, we cannot, mostly cases, recrossing is feasible for all cases. So this is experience. I think that this is experience. So next case is, what is the next case? Sorry.
Complication.
Complication. So if the complication occurred, we need manually. But so far, we can select the patient is a risk of the complications. Low case, maybe I selected. So it is very important thing. So in this situation, if the occurred complication, ASAP change the manually. It is important things. So guiding catheter selection is slightly different because the robotic PCI is important thing is the keep the guiding catheter backup position. So mostly use unplugged or extra backup catheter we use. So it is such a situation is different, completely different from the manual catheter. So third is what is third? Sorry. Third question.
The radiations of the patients.
Oh, radiation. Oh, okay. I understand. So basically you understand. Yeah, theoretically you understand the for operator is away from the catheter level, so we cannot expose all that. But the patient is the same situation. Why is what is the reason? Is the low exposure reason? It is one is a merit is a, so maybe the operator decided to use a CT and previous angio. So only use a X-ray during during the PCI procedure. So, but manually we also check fluoro. You understand? You know. So in that situation is increasing the fluoro time is increasing. So the robotic PCI decrease the patient radiation. But sometimes it is difficult. So about the robotic PCI, maybe the change the guide wire, then change the device. We cannot use a fluoro. Only the device because the device fixed. So we cannot use the fluoro. But manually, if you change the guide wire and most of the valve device, always you check angio because the guide wire is moved easily. So it's different. So I understand. So the patient merit is something little than operator exposure. But that is a reason. Okay. Thank you for question.
Thank you, Sensei.
Okay, Sensei. Thank you for your explanations. So we next is Dr. Nanda. Dr. Nanda is the interventional cardiologist from Harapan Kita Hospital. Please, your comment about those speakers.
Okay, thank you very much, Dr. Fujita. I'm really happy to see you here because usually I followed you on Twitter and there's so much knowledge
thank you.
from you. There is so much knowledge from you that I can learn. I would like to ask whether, we know that this technique of robotic PCI giving us some advantages, especially for the operators in reducing the radiations, exposure to radiations, and also preventing us from carrying a heavy apron on our back and also on from our hips. So, but that maybe there's a time to adapt from the conventional PCI to the robotic PCI, and how long do you adapt from this conventional system, non-robotic PCI to the robotic PCI? Is there any difficulties from converting from the conventional PCI to the robotic PCI? Thank you, Dr. Fujita.
Thank you.
Okay, Fujita, is there any comment for your that?
Yeah, Dr. Fujita, I would like to ask questions with how long the adaptation.
How long?
Yes,
it is very difficult because it's yes. How long? How long? What do you mean? How long?
We used to do the conventional PCI, and then you train to do the robotic PCI. And how long do you need time converting from the conventional PCI to the robotic PCI?
Conventional. Yes. First, I decided this patient is suitable for the robotic PCI. So the convention to change the manual it is so quick because the wiring is very difficult. I decided to change the manually so quick. So not so take a time to decide it to the conversion. So totally is a robotic PCI totally procedure time is a very short than primary operator doctors. So because this data is mainly I was done. So the no primary or amateur or the beginner doctor cannot use. Only the expertise doctors. So it is not so long time to take a conversion. Okay.
Okay. Bit quick and checking for manual PCI to from manual PCI to robot text. Your experience, maybe 6 months or 3 months, Professor Fujita. Okay.
Yeah.
Okay, thank you.
Thank you.
Next to the is Dr. Dr. Vidya is our young cardiologist. Maybe next will be in your center, Dr. Vidya. Okay, Dr. Vidya.
Yeah, thank you, Dr. Risman. Thank you, Mr. Fujita. It is truly has broadened our knowledge, your presentation. Okay. Well, yeah. I think you have presented those patients who are suitable for this robotic PCI. While I'm interested, it's which are patients who are not suitable for robotic PCI in the beginning. So when you see the patient, like you would say like this is not suitable at all for the robotic PCI, then you would go for the manual PCI. So what kind of patient which are not suitable at all from the beginning? Thank you.
Thank you. I think the robotic PCI is sometimes difficult to decide the indication. So one of the problem is backup is so important because the device advancing, guide wire advancing is need to back up the guide wire. But in manual, so we cannot use a guiding position and something. So we can get more backup to use a normal guiding catheter. But the robot is so difficult in that situation. Like robot is maybe sometimes difficult to deep seating. The deep seating. So the first we selected a robotic PCI is backup is easy. So the guiding catheter not so difficult. So I decided in this situation, and I decided kissing band technique is okay, and DK crush is okay. But classification and totality, the situation, I think this is not suitable for the robotic PCI. So I selected a patient. But as you can see, type A, type B1, B2, and type C. So type B region is more because our facility has a lot of PCI case with a complex region. So that's the answer. It is something that very difficult. But expertise doctor, easy to decide to, it is okay the robot or it is not okay the robot. Okay.
Thank you, Mr. Fujita. So classification and CTO, mostly those patients are not suitable for robotic in the beginning, right?
Yes, so yes, that's right. But in America, Dr. Lambardi, Lambardi sensei, Dr. Lambardi crossed the guide wire to change the robot, after the crossing the wire. He decided to change the robot system. But I think CTO region, it is very, CTO is need to wire crossing. After that, it is difficult to advance the device. So I cannot use a robotic PCI for the CTO region so far.
Okay, thank you very much.
Thank you.
Okay, thank you. So it is excluded for maybe for the last there's some questions for me about the corridors. Why corridors retract from the development? So there is a new one. What happened? What happened?
What happened? Yes. This is my private opinion. So the first is Siemens acquired the corridors for expanding the robotic system. But after acquiring the robot system, the Siemens maybe decided this is not so good for the PCI for the cardiovascular image, cardiovascular field. So Siemens decided to change the mind. So from the cardiovascular to the neurosurgery. The neurosurgery is easy to robotic system. So they decided the manual robotic PCI trend cardiovascular from cardiovascular to neurovascular. So this is true. But unfortunately, R1 is made by microport. It's suitable for the coronary system because the wiring is so different. Corinda's wiring is very, we use ROR. It is sometimes difficult to control the wire manually. So only use the application. But microport, I was experienced one case. It is easy to negotiate manually, robotic manually. So fantastic. So I think robotic Corinda system is basically not suitable for the coronary artery because the wiring negotiation is so difficult. That is the answer for suitable for the neurovascular. Okay.
Okay, thank you,
Thank
Fujita
you.
Sensei, for the explanations. So your comprehensive lecture and fantastic open our eyes about the new technology in the cardiovascular intervention, especially in the robotic PCI, and the robotic can use in any kind of PCI. Maybe exclude for CTO. And the first speaker, Dr. Amin Subandi, give lecture about minimal invasive surgery. Of course, very important to think about the suite indication for the minimal invasive surgery approach in patient with any kind of cardiovascular disease, including valvular heart disease, coronary heart disease, and structural heart disease. And for both speaker, Professor Fujita and Dr. Amin Subandi, due to the time, so limited time, we, as the moderator, thank you for your attending here as the speaker, give a lecture, very advantage, very important and tremendous lecture from both of you. So we're waiting for you, maybe Dr. Fujita Sensei, next year you will give lecture for new Corinda's Reborn, new R1 robotic catheter.
Okay.
Okay. We waiting for your lecture next. Okay, so I think the limited time. Thank you for the panelists, for the speaker and all the attending here and all the participants for attend this webinar meeting. So we close the meeting. Oh yeah, maybe. Oh, is there any question for participant? Maybe before we close, any participant? So I think no have a question for any participants. Okay. Yeah, siapa ini? Okay, from chat maybe. Okay, but limited time. Okay. Okay, Professor Fujita Sensei and Dr. Amin and all the panelists, thank you for your attend of webinar. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Bye. Thank
Bye.
you.
Simon-san, bye.
Okay. Thank you, Dr. Amin, Professor Fujita, and Dr. Isman Firdaus for bringing us the productive session for today. Ladies and gentlemen, on behalf of National Cardiovascular Center Harapan Kita, I would like to say thank you for your active participation today. We are signing off and we will meet again tomorrow. Thank you very much. Good morning.